Fantastic.
All right, now that we're officially recording, it's my pleasure to introduce our guest speaker for today, our Brain Health Conversations on Brain Health series. And this is the last event before we break for the summer. And we are finalizing details on what we are doing in the summertime. It's going to have a different approach, but hopefully equally beneficial and interesting. So I'm going to let Katie at the end give some details. Yet there are some details are still kind of like finalized, like dates and stuff. But we are very excited to introduce the summer events. But before we do that, I would like to introduce our speaker today. We have Dr. Monica Di Iorio. Monica is a neuropsychologist working at Rush in the behavioral neurology department, and she is also part of the brain health program at the MS Center. Monica has been instrumental in helping us run the Cognition Day for the 3-week brain health program. And also she's been one of the faculty lead for the Neuroresilience Clinic, which I have to be honest, I did not know about the Neuroresilience Clinic up until I joined Rush. And that was one of the many positive surprises that I learned after I came to Rush, because it's a very unique clinic, and it's something that I'm very pleased to be able to offer as part of the ancillary services that we have in the Brain Health Center and in the MS Center. So I'm going to let Monica explain more details about that. But before we do that, Monica, thank you for being here. Thank you for everything you do for the MS group. And now the floor is yours.
Okay, thank you so much for having me. I'm excited to be here. I have some slides I'm going to share, so I'll need you all to bear with me for just a moment here. Okay, share this. Oh. All right, let's see if I can see you all now. Oh, there you are. I think I have a little bit of a lag. Can someone give me a signal to let me know you're seeing slides?
Not yet.
You're not seeing slides.
Still pulling it up. Maybe if you give it a second.
Okay.
Yeah. There you go. There you go.
Great. Very good. So, I'm just trying to see that I can see chat. All right. Okay, well, we're going to go ahead and get started. So I am happy to be talking with you all today about cognition in multiple sclerosis. And as you can see from my title here, I'm really going to be focusing on cognitive intervention. And so what can be helpful in either improving cognition and thinking abilities or preventing onset of those things, or finding workarounds once there are some cognitive difficulties present. And so as a neuropsychologist, I have specialized in thinking abilities and understanding thinking abilities, measuring them, and thinking about how to work with any difficulties that show up. And so I really enjoy talking about all of this. So I have a little outline. We're going to start by talking about what potential cognitive changes could be seen in multiple sclerosis, what those look like. Then we'll move into talking about what can be done about it. What are some strategies or treatments that can support thinking abilities or cognition? And we'll spend a little time talking about mindfulness as one of those treatments or strategies that can be helpful for thinking abilities. And then we'll end by talking about our cognitive resilience program that Dr. Miravalle mentioned, and other resources like on the MS Society website that are available to you all. So in multiple sclerosis, as you might expect, and maybe some of you know already, there are cognitive changes that are commonly seen throughout the disease course, but these can show up for a number of different reasons. So we might see cognitive change related to multiple sclerosis itself, because of the changes that are happening on the cellular level to the myelin, this kind of fatty layer around our neurons that help our neurons fire efficiently and work efficiently. As that breaks down, we can see cognitive difficulties, as well as when there's damage happening to the nerve cells themselves, or if there's loss of brain tissue over time, that can, of course, lead to some thinking difficulties. That's not the whole story, though, and we know that's not the whole story because some people who, when we do brain imaging and see there's been changes in the brain, actually don't have that much change in cognition and are doing pretty well. And some people have sort of the opposite. We don't see as many changes in the brain, and we see more cognitive difficulty. So that can be confusing to make sense of. But part of what's going on is, in addition to MS and changes in the brain happening because of MS, we have some other things that could cause difficulty just on the day-to-day for people. These might be related to MS, but they could be related to other things entirely, like fatigue and poor sleep. Like pain is very distracting and pulls our attention away, and mood and adjustment factors. Really, all of these I consider kind of internal distractions. When we have pain or anxiety, all these thoughts bouncing around in our head, or we're feeling really tired, those things are taking up attentional resources. So our attention is going somewhere else. We're not able to fully pay attention to maybe what I'm saying right now, or when you're trying to learn something new, and that becomes more difficult, even if there hasn't been changes in the brain itself. And other health conditions, both other physical health conditions and mental health conditions, can lead to some cognitive difficulties or thinking difficulties. And on the other side of things, I actually don't have this up there, which is a blind spot on my part. But on the other side of things, we have to think about all of the strengths that someone is bringing to the table to begin with. So background in education and work history, even hobbies, things that you really enjoy doing and spending time on and learning, exercise, all those things that you have already in your life that help make you a healthier and happier person, also make your brain stronger and can help balance out some of these difficulties that we might otherwise see.
So Monica, I'm gonna interrupt you for a minute because you said a lot of very meaningful things, and I want to highlight some of those. And I'm going to use also the opportunity for the audience to feel free to write questions in the chat box. We want this to be interactive as much as we can through this platform. So please feel free to write your questions. But Monica, you started by saying the difference between structure and function of the brain. That sometimes, when we do MRIs, we look at the structure, and sometimes patients ask me, well, can you tell if my brain looks like I may have some cognitive decline in the future? And, we often struggle with that because, as you said, sometimes these structural changes, whether it's lesions or even atrophy, may or may not correlate with the function. So what can you speak on how the brain works in terms of, the number of neurons is important, but also how these neurons talk to each other and they connect with each other perhaps is more relevant. What can you say about that?
Absolutely. The brain is amazing. And so the connections that happen in your brain, our brain is, we call it plastic. So that means that it can adjust essentially. So even when there's been changes in the brain structures or damage in brain structures, there can be new connections made in other areas of the brain that help compensate or work around an area that's changed. So while there may be an area where there's damage in the brain, there's a lot of other areas of the brain that are healthy. And if those connections are strengthened, and if you practice new learning and new strategies and exercise and all of these behavioral things that are highlighted throughout the brain health clinic and these conversations, that really helps to form new connections and strengthen firing within the brain in different ways that can help the brain function better, even when there is lesions or changes in the brain structure. And that's
Excellent.
actually part of, if I put in a plug for neuropsychological evaluation, that's part of what makes those evaluations helpful, is that we can measure functioning and see how someone's memory is working or attention is working, which is different than what you get from an MRI or a picture of the brain.
Excellent. And I saw a question from Shane, and I know you will be addressing that in future slides. But so I'm glad you brought the concept of learning, and you know, I always remember one of my dear professors in neurology. He said the number one function of the brain is to forget. And we always think of the brain as an organ that learns, but actually we are constantly forgetting things. And that's a normal process that the brain has to kind of triage what information is going to be meaningful enough to be stored. And like 90% or more of what we are exposed to, we forget because the brain doesn't feel that that's important. So in the sense, the brain is very efficient at forgetting. So the process of learning is an active process, something that we have to, in a sense, put effort. Otherwise, it's probably not going to happen very easily. Very linked to that is this concept of attention. And I'm glad you mentioned attention deficits very early in the presentation, because the way I look at attention is that it's almost like the quarterback in a football team, right? It's just that function, that cognitive domain that when it is decreased, it's going to affect many other domains in cognition. We cannot remember something that it was not stored in the brain. And in order for that information to get stored, we have to pay attention. That information has to get to the right places, and then we can retrieve it. So what can you say, or maybe speak on these attention deficits that you encounter in multiple sclerosis patients?
Yeah, so I actually want to move ahead. I have that here to help me talk about it. I'll come back to that. So very commonly, when we measure different thinking abilities in MS, we see difficulties in these areas of thinking. So processing speed, or speed of thinking, very quickly being able to take in information, think about it, process it, and memory. Now, forgive me as I skip ahead here so I can answer your question. These are some other areas of thinking that can be affected. But when we think about memory, there's multiple components. And part of memory is really attention. So before you can remember anything, you have to be able to take it in. So the first stage of memory is sometimes called encoding. And this is basically attention and what we call working memory. So what you can take in the moment, and then you can work with it, move it around, think of what you want to say next in conversation, do mental math, whatever it might be. If you want to hold on to that information for later, it has to get saved into long-term storage. So at this point, there's information somewhere in your brain, but you're not experiencing a memory yet. That experience of memory comes at the last stage. This is retrieval. So at a later point in time, you can take out the information again when you want it. Now, these three stages go in order. And so if you have difficulty with attention here at encoding, you might miss a little bit of information, never get stored, and it's not there when you want to get it out later. Or you're not missing everything, but you might get it in a kind of weak way. You might learn the information in sort of a disorganized way or a surface level way, and it's stored that way. And so again, when you go to get it out later, maybe it's there, but it's harder to find. It's more effortful. It takes more time. So that's how when you have attention difficulties, it can show up like other difficulties, especially memory difficulties, but even language difficulties. Sometimes people talk about word finding. It's a very, very common difficulty where you know a word, you know a word, but you can't quite pull it out. Many different things can cause that. And even if you're having some distractibility, attention problems, frustration, that can affect that process. And we see this, I want to talk about this study, if you'll bear with me. I think it's a really nicely done study that demonstrates this and how this can work in MS. So the idea is oftentimes we measure memory with word lists. So for example, this is not a real word list, I made it up, but this is what it would be like. Someone would read a list, for example, cat, table, shoe, kite, nail, ocean, book, flag, map, nose. Then I would ask someone to repeat back as many words as they could remember. So there were 10 words. And in a certain study that happened back in '94, so a little while ago, there was a word list that would be read to individuals, some with MS, some without MS. And they would repeat the word list over and over until someone was able to remember all 10 words 2 times in a row. And this allowed the researchers to look at learning and how many times it took to listen to the word list before it was remembered. And what they found was that people with MS, on average, took about 8 trials of hearing the word list before they were able to get it correct 2 times in a row. People without MS were able to do that on average in about 5 trials. So it took people with MS a little bit longer to first learn that information. But once they learned it, 30 minutes later, both groups, people with MS and people without MS, were able to remember the list really well. There was not a difference between the groups. They were both able to remember most of the words, 9 or 10 words on the list. And so I know that was a pretty long-winded answer, but I hope that it demonstrates that people are oftentimes really worried about memory difficulties, understandably so. They have big impacts, can have big impacts on your life. And when the memory problem showing up in your life is more related to attention or encoding this initial learning, there's a lot of things we can do to actually strengthen that so that the memory part ends up working better. Does that make sense? Great.
No, absolutely, and actually clarifies this very difficult sometimes to dissect cognitive function of the brain, right? So that, it's always helpful, at least for me, to remind myself the brain has different functions, and even within the cognitive area has multiple domains. So you mentioned some of those, which is processing speed. And so can you maybe explain how will that clinically present? How can we tell that someone may have some difficulties in processing speed?
It's a good question. So it can show up in a number of different ways. Processing speed might show up like difficulty taking in new information in like a conversation. Sometimes people might be slow to respond or slower to respond to a question, needing more time to fully take in what was said and process and think of what they want to say next. That's a pretty common way that it can present. Sometimes it shows up like needing more time to complete tasks. Sometimes it can show up like making more mistakes in tasks, like even like emails, more typos, and that can come from not giving yourself the time that you need and trying to push through and rush through, and then being more susceptible to making some mistakes. So that's oftentimes how it shows up in day-to-day. And we oftentimes measure it. If you come to my office or a neuropsychologist's office, we measure it by doing tasks that you have to do as fast as you can. They're usually relatively simple tasks that are prone to errors that give you the opportunity to make mistakes. So we can look at both how fast are you and how accurate are you, and what's that balance. Everybody with or without MS has a payoff. You know, if you go as fast as you possibly can, you're going to be more likely to make mistakes. But we're looking for kind of that balance of being able to do things quickly and accurately compared to other people similar to you in things like age and education when we're measuring it. Okay, and I will mention, I'm just going to go back here for a moment so you can see here. There are some other areas of thinking that are commonly affected in multiple sclerosis besides speed of thinking and memory. Executive functioning is this, we call it higher order thinking. It's kind of like the executive of a company who helps coordinate the rest of the workers and does a lot of the background work in the company. Executive functionings in the brain help to do things like plan ahead, problem solve, organize, think flexibly. So if you're trying to problem solve and you're doing something one way and it's not working, being able to recognize this isn't working, I need to try a different strategy. And then things like verbal fluency, very quickly being able to pull up words, and visual spatial ability. Now, some of these areas of thinking might be affected by processing speed, right? So if that need to have some additional time to take in information, to process it, that could affect something like problem solving. Again, if you're trying to rush through, that's going to be more difficult. And these are areas that in the research, when we look at big groups of people, they tend to be more commonly affected in multiple sclerosis. But not everybody with MS will experience these things. And each person is going to experience something a little bit different as well. These are the types of things we might be looking out for, though. So I'm going to jump through these things we talked about already. Okay. I also wanted to highlight, when we're thinking through, we talked about the difference between structural changes in the brain and functional difficulties in day-to-day life. I also want to talk a little bit about how there's a difference between perception of cognitive problems or the experience of cognitive difficulty in day-to-day life and cognitive impairment. They're not the same thing. So what I mean by that is, for example, there's been some studies to look at in multiple sclerosis specifically, how do people think about their experience? What do they report experiencing? And then measuring thinking abilities with different tests and seeing who has measurable cognitive impairment. And so you can see here that in one study, there's been overestimation of cognitive impairment, that when we ask people, do you have cognitive difficulty? In this study done just last year, 2023, almost 80% of people with MS said that they had at least mild cognitive deficits. And when they were measured and tested, we saw about 50% had impairment on at least one area of thinking. And so there's this discrepancy where more people, that's about 30 people who didn't have any cognitive impairment, who said, yes, I have some cognitive deficit. And we see this in lots of different areas of different neurological conditions. Very often we see a disconnect between what someone is reporting, they experience in day-to-day cognitive difficulties, and then not always linking up with what we measure in testing. So what could explain why they're are experiencing or perceiving these problems, but there's not an impairment there? There's a lot of different reasons. So one is sometimes there's a misattribution of normal aging. There are some normal cognitive changes that happen across the lifespan that start pretty early, start around your 30s. And so really subtle little changes that can be noticed. And sometimes when you have something like MS, we see this a lot in other conditions like traumatic brain injury. If you have something that is linked to thinking difficulties, sometimes every time there's difficulty with attention or you forget something, something goes off in your mind and says, oh, that must be the MS. And it's scary. It can be scary. But it's not always true that the cognitive difficulty that's showing up is related to MS or a neurological problem. Sometimes it's just normal. Sometimes in multiple sclerosis, people who have more physical slowing report more cognitive difficulty. So there's some research to suggest it's really difficult to parse apart when you're having some physical difficulties from when you're having some cognitive difficulties. Sometimes there's anxiety or depression that's coming up, and that can affect our thinking abilities for a number of reasons. Some researchers think it's because of rumination. So we have all of these thoughts that kind of get stuck in our head, and we replay them and replay them and replay them. And that's distracting and distressing, and that causes difficulty. Sometimes there's concern for changes in self-efficacy or low self-confidence, essentially. This can happen especially when you stop doing things that maybe you enjoyed or that are a little bit challenging. Sometimes when you try to do something and difficulties show up and you think, well, maybe I can't do that anymore, I'm going to stop altogether. That doesn't give you a chance to learn that you can do it. And maybe you can do it in a slightly different way than you could before. But if you disconnect and stop doing it at all, you've learned, I can't do this thing. And that can impact our self-confidence, make it more likely that we're going to be more anxious if we try it again, or we're just going to hold this belief whether or not it's accurate and not do something that maybe we enjoy or is meaningful to us. And things like fatigue as well can interfere. So I'm about to transition here, but perhaps this would be a good time. I'm going to move into, now that we've talked about what can be seen cognitively in MS, what might be helpful. That's our next area. Are there questions before I move on?
Yeah, I think there are a few in the chat box. So there is one that says indication how the cognitive changes could be treated to MS versus other factors, which I'm sure you're going to cover in terms of the assessment that you do. But I want to ask one question regarding to the previous slide, which has to do with the tools that we use to measure cognition. And there is some ceiling effect that usually happens particularly in individuals that perhaps are highly educated, or they start from a cognitive function that is above average. I mean, most of these tests that are used have been validated in a large number of patients and individuals, and usually it's been established that the minimal threshold to consider normal versus impaired is determined by a mean of an average individual. But sometimes we see clinically that patients that are starting from a very high level of cognition, they themselves identify worsening, and we can't truly capture that with the formalized tests that we use. So can you speak a little bit about that, whether the tests that you can still correct for some of those higher level of education?
Absolutely. So I will answer kind of both of these questions together, actually. I don't have any official slide on neuropsychological evaluation, but neuropsychological evaluation is providing these tests that help to measure different areas of thinking. All these different areas of thinking we've already talked about, and others. And these are tests, like Dr. Miravalle mentioned, that have been given to many, many people and well researched. And what we have is a group of norms, of information that tells us where the majority of people score for different ages. And oftentimes we can adjust for things like education level as well. And we do things like having, when we don't have a baseline evaluation, which oftentimes isn't needed because of these other tools that we have, there are certain areas of thinking, reading ability is one of them actually, that tend to be pretty stable even when there are neurological changes in the brain. So we use things like reading ability, adjusted for age and education, and sometimes even area that you grew up, to estimate where we might predict how you would perform on everything else. So we estimate your cognitive functioning, where it would be without MS or some other interfering factor. And then we do measurement. And we can adjust. There are different tests, and some tests are more difficult than others. So sometimes if we know someone is very high achieving and highly educated, and we expect them to be performing very, very well, we might give a more difficult test so that we can pick up on cognitive change. Now, our tests aren't perfect, they're just tools. So it is possible we don't pick up on some subtle difficulty at times, but we try to adjust for those things. And then I believe the question was about how can you parse apart what cognitive change might be related to MS versus something else as well. And part of that comes from, if we look at those norms that I was mentioning, if the question is there normal aging versus MS? We can answer that question really well because we have lots of adjustments for age. It gets more difficult when we're trying to understand what might be related to anxiety or depression versus MS. We do our best to parse that apart by looking at timeline. So we usually, if you come in for an evaluation, we spend a really long time with you. So we might spend an hour talking together about your life history and your experiences, and then we might spend 3 to 5 on the long end, maybe 2 on the short end, 2 to 5 hours measuring thinking abilities. So we're together for a big chunk of time, and we look for patterns that match up with what we might expect with different conditions. Sometimes we don't know 100%, and we think, well, it's some constellation of these things. Let's work on the things that are most changeable. Let's treat the anxiety and depression. Let's make sure you're managing your MS and other health conditions, and do everything we can to keep you as healthy as possible and to take away any interfering factors that could be impacting your thinking abilities. All right. I apologize, I can't see the chat, so I'll keep checking in periodically to see if there are other questions. Okay. So in thinking about all the things we just talked about, what might be interfering with thinking abilities, one of the things that can be helpful is psychotherapy. So in particular, if there is depression or anxiety, which do occur at an increased rate in people with multiple sclerosis. And I've mentioned anxiety and depression a couple times already in some ways in which they can interfere with thinking abilities. I like to highlight that when we diagnosed depression or anxiety, we look at groupings of symptoms. So we're looking for, is there a certain experience that a person is having, a number of symptoms that are showing up in a certain way that looks like depression or anxiety. One of the symptoms in depression, this is taken straight from how we diagnose, is diminished ability to think or concentrate or indecisiveness nearly every day. Similarly, a symptom of anxiety is difficulty concentrating or your mind going blank. So I highlight this because I think sometimes people discount how much mood factors can play a role in our thinking. But attention difficulties are so much a part of the experience of anxiety and depression that it's really a part of how we define what they are and how we diagnose them. The good news is there's really good treatments for anxiety and depression and other mental health conditions. Cognitive behavioral therapy is a type of treatment that has been researched a lot and is very effective, teaching people how to identify thoughts that are showing up and work with thoughts that might be unhelpful to try to adjust them to be more helpful thoughts, and how to make some changes in behaviors that are going to support mood and fatigue as well in this study. Cognitive behavioral therapy for depression and fatigue in people with multiple sclerosis. As depression symptoms went down, we also saw a reduction in cognitive problems that were reported. So we can see how those two things are linking together. Now, in addition to psychotherapy, there's something called cognitive rehabilitation. Now, cog rehab might be done by a psychologist, especially a neuropsychologist. Sometimes occupational therapists or speech and language pathologists do some cognitive rehabilitation. So there's a number of different professionals who do this type of work. And these treatments usually take one of two perspectives. So one type of cognitive rehabilitation is restorative in nature, where the goal is to reinforce or reinstate, so bring back skills that have been changed or decreased, usually through drill practice and repetition. Oftentimes these are computerized. This has been shown to be helpful for some areas of attention and processing speed. There's a bit of a mix of results in the research here where it's not entirely clear how improvements might translate to day-to-day life. So that's some of the difficulty with this type of treatment, is people seem to get quite a bit better at the thing they're practicing, but it's not as clear if it translates to day-to-day life things. The other way to do cog rehab work is working on compensation. So this is finding workarounds, using the strengths that you have and optimizing your strengths while working around any weaknesses that might be present. And that tends to have stronger research support for what's helpful in the day-to-day. There's a lot of research coming out more recently in cognitive rehabilitation in general and in cog rehab for multiple sclerosis. So this is a graph that is from a kind of summary article back from 2020 looking at cognitive rehabilitation work. And so the dark blue bar is showing studies that were published on cognitive rehabilitation in multiple sclerosis. And you can see there were less than 3 between 1993 and 2000. So very little information. And there's more and more, oh, I'm on the wrong screen. There's more and more over time with this boom between 2011 and 2015 and things kind of staying up there in more recent years. So if you dig into the research, or if you listen to me who has dug into the research, if you look at a lot of reviews of cognitive rehabilitation from even just 2014, there was some really good reviews that came out that said, well, we really don't have very good research support here. We need to know more. And we are still learning a lot, but I think there was a response to that call, and there has been more and more research coming out. So a more recent review in 2021 did say that there's been quite a bit of improvement in the quality of research that's being done in cognitive rehabilitation in MS, and that there is some research support. There's still things we need to learn and understand. There's a lot of limitations in the research even still, but we're learning more all of the time, and much of the research that's out there is encouraging. And so I want to talk about a couple of the things that have been shown to be helpful. One of them is called the modified story memory technique. And this is a treatment protocol. It's 10 sessions that teaches how to create mental imagery for words. So if you have to remember a word list or certain tasks, word lists you have to remember in day-to-day life, things you need to pick up at the grocery store, or if you need to remember to make a phone call for 3 different people, those are like word lists. So taking that information and linking it to mental pictures and making it vivid in your mind can be helpful. So an example of this would be if you needed to remember, you left your house and you think, oh, I have my daughter has a soccer game at 4 o'clock and I need to make a doctor's appointment, and I need to RSVP to a birthday party. Those are the things. You might pause and think about, okay, how can I make an image to link those things together to help me remember them? So I might think, okay, I'm going to imagine my doctor. Maybe it's Dr. Miravalle. So you picture him in your mind. And I might picture him holding 4 soccer balls and dropping the 4 soccer balls onto a birthday cake and smashing the birthday cake. It's kind of a silly picture, but that makes it more vivid. And so what we have is the doctor, soccer balls, 4 of them, because the soccer game is at 4 o'clock, and a birthday cake getting smashed because we need to RSVP to the birthday party. So pausing and intentionally making this vivid image that links information together can really strengthen that first stage of memory, that encoding. So you're more likely to remember it once you maybe get back home from running errands, or if you get to an office or something like that. You can think back, oh, what was that picture? Oh, those are those 3 things I need to do. The other thing that this treatment protocol teaches is context. So the story I gave a little bit of context, but the idea is if you elaborate on something, it can deepen that encoding, make you more likely to remember it. So instead of saying, oh, I need to pick up oranges at the grocery store, you might think, oh, I have to pick up really ripe, juicy oranges at the grocery store that I'm going to eat with my dinner later tonight. You kind of flesh out the information to make it more vivid, easier to remember. And then you would, in this treatment protocol, you would practice different ways to apply those to day-to-day life. Other research has been done on general learning strategies. This comes from a lot of research from cognitive psychologists that we know these techniques are helpful for learning in general. And then they've been applied in groups of people, taught to groups of people who have multiple sclerosis to see if they'd be helpful. So things like spaced learning, which means instead of cramming information in and trying to remember it all at once, or even just repeating the same information over and over and over in the moment, practicing it for a short amount of time, and then doing something else, taking a break, and then practicing it again in a half an hour, or even the next day sometimes. Spacing out that learning instead of trying to cram it all in at once is more helpful. And another thing that you tend to be doing when you're spaced learning is retrieval practice. So every time you bring up the memory again, you're practicing remembering it. So if you listen to this talk and then you later on explain something you learned from the talk to someone else that you know, that's practicing remembering. And then maybe write it down a third time. Now, each time you've brought up the memory and you've put it in your own words, and that can really strengthen your memory. And then a third type of compensatory strategy treatment that's been studied is kind of general strategies that are helpful to support your overall thinking abilities. Things like using backup systems like calendars and notebooks, reminder systems can be really helpful. Reducing distraction, that can look like doing only one thing at a time. It can look like, if you tend to go to your phone a lot, turning your phone off or keeping the phone further away from you so you're not tempted to pick it up right away. Stepping into a separate room when you have to have a conversation. And even doing some coping strategies that you might learn in more traditional psychotherapy to help. Because when you get frustrated, understandably frustrated with memory difficulties or attention difficulties, it's not so helpful. It tends to make it worse. So the more you can work with kind of coping with that, finding things that work for you, the better. And what this is from the more recent big review that came out in 2021. They looked at 44 studies for memory compensation in multiple sclerosis. And their conclusion was there was pretty high evidence for improving subjective memory. This is the perception of memory. So people feeling like they have better memory in day-to-day life and better quality of life after this type of treatment. We need more research to really understand changes in on neuropsychological testing and also to understand how these changes might last over time and doing better quality research in larger groups. There's still work to be done, but I think it's encouraging, as I mentioned earlier. So I'm recognizing we're very close on time here. I want to mention a couple other things, but I'll try to be brief here. So in addition to all of those interventions I've talked about, in the last few years, there's been some look at mindfulness-based interventions. Mindfulness, if you've never heard of it before, is paying attention to the present moment on purpose in a non-judgmental manner. So oftentimes, people in general, as humans, we tend to spend a lot of time in the future. What's going to happen? What do I need to do? What are they going to say? And a lot of time in the past, why did this happen? Why did I do that? Or replaying memories in our head. Relatively little time is spent fully present in the moment. And so in mindfulness, sometimes I say mindfulness is like the opposite of absent-mindedness. Instead of being go, 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 just doing whatever comes to mind in the moment, it's being intentional and taking your time. And there's a lot of mindfulness strategies that typically are sit down, focus on something like your breathing, or you could go for a mindful walk and bring your attention to your senses. You could do it doing almost anything. And this has been applied to attention in general, because what you do in mindfulness practice, pull your attention to the moment and you notice. You notice when you get distracted. If you get distracted 100 times in 2 minutes, that's really good practice. You've got a lot of reps in. So you're practicing redirecting your attention. And so there has been this study that was done between 2017 and 2020. It looked at teaching mindfulness versus a cognitive rehabilitation group versus treatment as usual, which wasn't much treatment. And what they found was there was improvements in mood, improvements in depression, improvements in quality of life, and fewer cognitive complaints for both the mindfulness group and the Cog Rehab group. And the Cog Rehab group also had a more positive effect on personal goals down the line. Now, these changes were present right away after the treatment. They weren't present 6 months later. So that's one of the things they want to keep looking at to understand if people stopped practicing the strategies, what could we do to help keep things consistent across time. So yeah, more research needed. We don't have time to practice, but I encourage you to look up a mindfulness exercise. There's a lot out there. I like to use the Mindfulness Coach app, which was developed through the VA, actually. It's freely available. There's a lot of mindfulness practices there. And then I'll end by talking about the resources that are available. So here at Rush, we do have, as has already been mentioned, we have this cognitive resilience program. Our cognitive resilience program is, it's really a follow-up to our neuropsychological evaluations. So if you come in for a neuropsych evaluation, in traditional neuropsych evals, you come in, you work with a neuropsychologist for a few hours, and then you might come back to get results in a couple of weeks, and they give some recommendations, and that's usually it. And then you would go back and follow up with the doctor who referred you. And we wanted to help support people in following through with the recommendations that we give, and to be able to give some of the cognitive rehabilitation treatments that I talked about earlier. So we have this option where we will meet with people. It's meant to be a brief time-limited treatment. We usually start with 5 or 6 sessions. We can add to that if people need it and if it's helpful. And we'll teach some very personalized skills to compensate for difficulties that are showing up in someone's life. We'll also address some mood difficulty if it's helpful and needed. If that's the main thing causing attention or memory problems or cognitive problems, we might refer you to someone else to do cognitive behavioral therapy or a different psychotherapy. But we oftentimes will talk about that and maybe teach some mindfulness to address it. I also wanted to point you to the National MS Society website. Under their Managing MS Cognitive section, they have this cognitive health in multiple sclerosis page with some videos and lists of strategies, many of which we talked about today, but that might be a helpful resource for you to review as well. So we have 5 minutes, I think, if there are questions or comments.
I am going through the ones I was sent privately. I don't know if you all were sent any private questions as well. Some of the ones I actually received from the content you put out today, I think would probably be better addressed one-on-one and offline about specific situations rather than in a group setting. But let's see if there's any larger outstanding questions. I think there was a question you touched on a little bit. Can any of these mindfulness activities be done prophylactically to prevent decline or onset, or how does that work or look like to you?
Yeah, perfect. I'm actually seeing that come through now that I closed out the share screen. I can see the chat again. So yes, you can. Many of these strategies are helpful strategies in general, and so there's a concept in other neurological conditions called prehabilitation, where we actually teach these types of strategies really before there are any difficulties present. And it can be helpful in keeping your brain healthy over time, especially things like mindfulness and working on mood and sleep and exercise. Those things are really helpful for supporting brain health before difficulties are showing up. And then if you are using other strategies like calendar use, having a really good calendar use or backup system in place is helpful, even if there are no cognitive difficulties present. And then if those things show up later on, that can actually be really helpful because you have something you've already learned and is in place that you can continue using or just tweak a little bit instead of having to start from scratch and learning something new.
Yeah, just to add to that, there was a recent study looking at functional and structural changes in the hippocampus, which is a part of the brain that helps to store memories. And they looked at MS patients that didn't exercise. They have a second group that were patients that exercise on average 150 minutes per week for 6 months. And they looked at patients that had already cognitive decline, and they measure what are the effects of exercise in all three groups. And individuals actually who had a baseline exercise activity of 150 minutes were the ones that actually benefit the most. Of course, the ones with cognitive decline and went through exercise therapy, they had a benefit, but the benefit was higher in the individuals who had a baseline of physical activity before the decline occurs. So that supports this idea that you don't have to wait for deficits in order to get the benefits from the therapies. So it's never too early to start getting, healthier, to exercise, to do all these wonderful things that we are learning that relates to brain health.
Yeah, there's never a bad time to start doing those things. Never too early, never too late.
And well, I would like to thank Monica Diorio for that wonderful presentation. That was very, very helpful, very clear. So thank you again for everything you do, Monica. And of course, if patients would like to follow up with you, they can find you, of course, at Rush, or they can send us a quick email and we'll be happy to provide more information. But before we adjourn, we were talking about brain health, we talked about education. So again, I'm gonna put now on Kathy to tell us more about the brain health program and when is the next one. And then Katie, if you can close and give us some updates on the summer programs that we have lined up.
Fantastic. Yeah, and I also want to say a huge thank you to Dr. Diorio. This was fantastic. I think it was really useful information. I always learn as well, so this is great. Thank you.
Thank you for having me.
Our next multiple sclerosis brain health program, that's a 3-week educational program where we meet during 6 live sessions. That's not going to be until towards the end of the summer. So we have a little bit of a break during June and July, but we'll meet up again on August 20th. And so anybody who's interested is welcome to email me directly and I can send along that registration link. But as I said, the summer program will be running August 20th through September 5th. And it's always on Tuesdays and Thursdays.
Perfect. And then just as a quick plug for either everyone that's listening live or when this goes on My Autonomy in about a day or two, whoever's going to start listening then, this summer we wanted to try to do a spin on these conversations on brain health that, they've been very sort of lecture based the past few months. And I think we wanted to see how we could expand it. So coming this summer, with details coming later, we're looking to do some demonstration cooking classes on surrounding the MIND diet, which if you're not sure or you don't know what the MIND diet is, I won't give it away now because we're hoping you're going to attend our webinar and cooking demonstration and learn more about it. But it's sort of a diet program that's geared towards, supporting brain health. Again, free to attend for attendees. We just want to get the word out and get you all some, very useful resources, and it'll be run by a dietitian and a chef that are affiliated here at Rush. So that'll be our June, July, and hopefully August conversations instead of these typical Monday night sessions that we've been doing for the past few months. So hopefully have some information out on that in the next couple of weeks.
Excellent. Well, thank you again, this wonderful team, and thank you everyone to our wonderful audience. We have a lot of individuals that follow up every single month, and we love to have you here, and we can't wait to see you hopefully in future events. And everyone, please use your brain in the best possible way and keep remembering. Thank you for your attention, and we'll see you next month.